Now, renal tubular acidosis. You know, kidney has got one head and one tail. You have a proximal tubule, distal tubule. What is the purpose of proximal tubule basically? Whenever glomerular filtration occurs, glucose, bicarbonate, everything that drains into the proximal tubule immediately will be recovered by the proximal tubule. Hence, proximal tubule is also called workhorse of nephron. That's the reason if you look at the proximal tubular cells, they will be very rich in mitochondria, because that is a place where all work of retention will occur. Then when the tubular fluid reaches the tail, collecting tubule, what is the purpose of collecting tubule basically? It vomits H plus ions produced in the body. Your ketone bodies are acid, urea is acid, lot of metabolites in our body are all acidic. So the distal tubule's function is, acid is after all H plus ions. It will actively secrete the H plus ions is the function of collecting tubule and distal tubule. Now, why will acidosis occur? If the distal tubule lost its ability to secrete H plus into the urine, there can be development of acidosis. Or the proximal tubule lost its ability to reabsorb the bicarb, then also acidosis will be there, because bicarbonate is the normal buffer. So that is the story of renal tubular acidosis in general. Now, whenever acidosis is there, whether it is diabetic ketoacidosis or ketone bodies or uremia or anything, the anion gap will increase. I thought of actually, I didn't get time today to prepare for the class. I mean, time to prepare good slides for you. First we need to discuss what is meant by anion gap, and then discuss what is high anion gap, normal anion gap, and come back here. But assuming that you are already good in all that background theory, tomorrow anyway I will discuss in detail at least half an hour what is urinary anion gap, plasma normal anion gap, how does acidosis differ from one another. For now remember, how do you calculate anion gap? Sodium plus potassium minus bicarbonate plus chloride, right? सोडियम प्लस पोटेशियम वन साइड, उसमें से क्या निकाल देगा? बाइकार्बोनेट प्लस क्लोराइड. Now, where in serum? Now, if the person has got low bicarbonate, which is a negative ion, same time a high chloride, what will happen? Nothing will happen. Anion gap remains the same. Any acidosis which leads to not only depletion of bicarbonate but concomitantly a rise of chloride, such an acidosis is called normal anion gap hyperchloremic acidosis, is what you need to remember. That is what happens in renal tubular acidosis, is what you have to ultimately remember. So renal tubular acidosis is non-anion gap, hyperchloremic metabolic acidosis with a normal glomerular function, is what you need to basically remember. Either there is a decreased H plus secretion or increased bicarbonate loss into the urine, which lead to the development of renal tubular acidosis. There are mainly three types: 1, 2, 4. There is no 3. The guy who proposed renal tubular acidosis is poor in mathematics and numbers, even English also. Why? The type 1 he named distal RTA. Type 1 we expect proximal. Okay, maaf kar diya. Type 2 he called it as proximal. Chalo, wo bhi maaf kar diya. Then instead of calling type 3, he directly jumped to type 4. So somebody who did not know mathematics and got seat into medicine is responsible for all these problems. Okay, now type 1. Type 1 is not proximal, it is distal. Distal convoluted tubule, collecting duct. There is a problem. What is the problem? Inability to secrete H plus into the tubular fluid. Hence H plus ion remained in the body without being secreted. Now tell me, doctor, how is H plus secreted into urine, into tubular fluid? H plus combines with NH3 and NH4 plus is the one which is secreted into the tubular fluid and into the urine. Who gives this unique ability of producing NH3 to the distal tubular cells? Glutamine converts into glutamate and releases one NH3, and this enzyme glutaminase is uniquely present only in the collecting ducts and distal convoluted tubular cells. Hence they are capable of producing ammonia, which binds with H plus, and in the form of NH4 plus it is lost into urine. That is how H plus is secreted into the tubular fluid. If that ability is lost, H plus can't be secreted, H plus is pent up in the plasma, and that lead to development of acidosis, which is called type 1 distal RTA is what need to be remembered. Now, whenever there is an acidosis, what is the normal body reaction? The body will try to produce acidic urine or alkaline urine. No, if there is acidosis in my body, my kidney will compensate by getting rid of that acid into urine and I produce acidic urine. But the only entity where the urinary pH will never go below 6 in spite of severe acidosis in the plasma is type 1 RTA. Why? Because collecting ducts don't have an ability to secrete H plus. Whether body has severe acidosis, very severe acidosis, person is dying, they don't know how to secrete H plus. Hence, how do you recognize? Any acidosis you expect urine to become acidic if the plasma pH is acidic. But if the urinary acidification cannot happen, doesn't happen, even if you infuse acid into the plasma, urinary acidification, if it doesn't happen, then you point out the pathology to collecting duct and distal tubule and call it as type 1 RTA is what need to be basically remembered. Then what else will happen? There is an increase in loss of the sodium, calcium, potassium, sulfate and phosphate. All these problems occur because the collecting duct distal tubule are expected to retain sodium, retain potassium, retain phosphate, retain calcium. All those functions are also lost, hence there is an increased loss of all these ions. Because of that, the person goes into hypokalemia, nephrocalcinosis, severe renal stones. Now the question comes, why do they develop nephrocalcinosis? The reason is, if the tubular fluid pH in the distal convoluted tubule, if it is acidic, it prevents stone formation. But if it is alkaline pH, immediately the calcium inside the tubular fluid and oxalate will bind with each other and that lead to stone formation. And where do you find alkaline urine in the distal tubule? Generally, alkaline urine is not the nature. The pH of the tubular fluid in the distal convoluted tubule and collecting duct is never alkaline because of the H plus secretion. But if it is alkaline, it is a wonderful atmosphere and a right environment for the stone formation. Hence stone formation is very common in them. And since they lose calcium, they develop rickets, osteomalacia, etc. are the other metabolic problems. So summarize, doctor. They have hypokalemia, nephrocalcinosis, rickets and osteomalacia, and calcium oxalate stone forming nature because of the alkaline pH which encourages the calcium oxalate binding in the distal tubule. This characterizes the typical type 1 RTA, and never their urine can be acidified. Even if you acidify their pH to however the lower pH value. So that is the way you recognize it. Now, they will develop hypokalemia, hyperchloremia, non-anion gap metabolic acidosis with nephrocalcinosis and nephrolithiasis. Now tell me, doctor, what makes distal tubules to get damaged, forget their ability to secrete H plus ions? Underlying cause can be congenital, multiple myeloma, nephrocalcinosis, nephrotoxicity, medullary sponge disease, analgesic nephropathy. Any of them can lead to a distal RTA, which is called type 1 RTA. How do you treat? The acidosis should be treated by giving bicarbonate, and giving bicarbonate will also prevent them from developing the kidney stones. And they need to be given phosphate salts. Why? If you give phosphate salt, then that will lead to the distal convoluted tubular pH to become acidic, because that phosphate will be entering into tubular fluid and lead to formation of an acidic pH in the distal tubule. If the distal tubular pH is acidic, stone won't form. Hence we give phosphate salts to prevent alkalinization of the distal tubular fluid, and we prevent the nephrocalcinosis from developing. That is what you have to ultimately remember. Now, type 2 is proximal. Do you think proximal is going to land us in more problem, or distal is going to land us in more problem? In which scenario we will have more problem? Proximal is very important for bicarbonate, all electrolytes. It is like the mother in the home. If father is not there, also no issue. If the mother is not there, खाना नहीं मिलेगा, कुछ भी नहीं मिलेगा घर में. So they lose bicarbonate into urine, they lose potassium, sodium into urine, they become hypokalemic, hyperchloremic with non-ion gap metabolic acidosis. In children, one of the common causes leading to a proximal RTA, which is called type 2, is the Fanconi syndrome. Similarly, conditions like cystinosis, Wilson's disease, multiple myeloma, amyloidosis, any of them can lead to the proximal renal tubule to become dysfunctional. But in them, how is the distal tubule? It is continuing to secrete H plus ions, right? Secrete H plus ions. Hence acidification is happening. Until acidification can happen in the distal tubule, calcium and oxalate cannot bind with each other. So nephrocalcinosis, nephrolithiasis do not occur in type 1 RTA. Type 2 RTA, which is proximal RTA. You may say, sir, proximal RTA may bicarbonate is not reabsorbed, no? All that bicarbonate will go into the distal tubule, no? So no, that should lead to alkaline pH, no? Did you get that doubt? No? Huh? Okay, I assume that you got that doubt. Huh? So if you get that doubt, the answer is, until H plus secretory ability is there for the distal tubule, any amount of alkaline bicarbonate reaching will be neutralized. That's the reason, in spite of bicarbonate and urea, since secretory ability of H plus ions is there for the distal tubule, the distal tubular fluid never become alkaline in case of the proximal RTA, and hence there is no predisposition to nephrocalcinosis, nephrolithiasis is what need to be remembered. So how do you treat? Never do the mistake of giving bicarbonate to treat the acidosis in proximal RTA. Why? If you pump bicarbonate into them, all that bicarbonate will go to proximal tubule, it is not reabsorbed, it will come to distal tubule. Too much bicarbonate will, in the distal tubule, will overcome the H plus buffering effect, secreted H plus buffering effect, then they may develop stones, right? So that is the reason, don't give bicarbonate, and you need to give sodium restriction, and if you do sodium restriction, how will the things improve? The proximal tubule lost its ability to reabsorb sodium in the proximal tubule, tubular fluid. But from where is the sodium coming into proximal tubular fluid? It is coming from plasma. From where is the sodium coming into the plasma? From whatever that we are eating in the salt, in the chutney, in the idli. Now, if there is no chutney, there is no sodium. If there is no sodium in the blood, there is no sodium in the, there is less sodium in the proximal tubule. And if there is a less sodium in the proximal tubule, that is a driving force for the sodium to get more and more reabsorbed. And even that little sodium that is there become reabsorbed. So the idea of treating hyponatremia is not to give sodium, but to restrict the sodium intake in case of proximal RTA patients is what you have to ultimately remember. Now the next important entity which you need to know is type 4 RTA. In one word you can describe type 4 RTA. What is that word? Type 4 RTA is called hyporeninemic hypoaldosteronism. Hyporeninemic hypoaldosteronism. Where will you get this problem? I am having diabetic nephropathy. Normally who produces the renin? Juxtaglomerular cells will produce the renin when macula densa senses that there is a low sodium in the body. Don't ask me where is macula densa, where is juxtaglomerular cells. I thought of actually preparing all that. I didn't get time, as I told you. Assuming that you know for now, ग्लोमेरुलस है भाई, उसके बाजू में जो है उसको बोलते हैं juxtaglomerular cells. सर ग्लोमेरुलस के बाजू में क्या रहता? लिवर रहता, स्प्लीन रहता, उसका अंदर का जो सेल्स है उसको बोलते हैं क्या? juxtaglomerular cells. So that's a small homework for tomorrow. Where are juxtaglomerular renin-angiotensin system, doctor? Today, just a review after going home, because physiology is 20 marks in the NEET PG. Anyway, you have to read. There is nothing that stops you. Now, when I have diabetic nephropathy, my kidneys juxtaglomerular cells lost the ability to produce renin. Whether sodium is high, sodium is low, potassium is high, potassium is low, I don't care, I don't produce renin. Said the juxtaglomerular cells. If there is no renin, there is no angiotensin. If there is no angiotensin, there is no aldosterone. And normally what is aldosterone will do? It retains sodium and kicks potassium H plus into urine. That kick will be missing. If the H plus and potassium can't be kicked into urine, where will they remain? They will remain in the plasma. And when they remain in the plasma, what does it lead to? Hyperkalemia, excess H plus lead to acidosis. Now here comes the fix. What kind of potassium disturbance did you see in the proximal and distal RTA? Type 1 and type 2? Hypo. The only form of RTA which is hyperkalemic is type 4 RTA, which is hyporeninemic hyperaldosteronism. Hypoaldosteronism. is the underlying pathology in the patients of diabetic nephropathy and interstitial kidney disease is what need to be remembered. And in them, since there is no aldosterone, there is no reabsorption of sodium, there is no secretion of H plus K plus, hence H plus K plus will be pent up in the plasma, leading to acidosis and hyperkalemia is what need to be remembered. Okay, doc? Now, type 4 results in hyperkalemia. Then, what is the problem in type 1, type 2? Type 2 is proximal, RTA. In that, bicarbonate is not reabsorbed, it is appearing in the urine. Hence, how is the urinary pH? How is the urinary pH? Alkaline. Alkaline. Of course, you are saying that H plus is secreted just before you told the doc. That's right. But generally urinary pH is alkaline. Okay. But if you give an acid into the blood, then acidification can occur in the urine, and urinary pH then from alkaline nature can convert into acidic. That's possible in case of proximal RTA. That is never possible in case of distal RTA. Even if you acidify the plasma by administering ammonium chloride, a common acid into the blood, if it is a proximal RTA, since that acid which you infused into the blood can be secreted and urine can be acidified, which is otherwise an alkaline urine. But in case of distal RTA, even if you give ammonium chloride, you can't acidify the urine. But otherwise, distal RTA, proximal RTA, if you collect the urinary pH of the guy, there will be alkaline pH. Why alkaline pH in proximal RTA? Because in proximal RTA, bicarbonate in urea is there. Why alkaline pH in the urine in distal RTA? Because in distal RTA there is no H plus secretion, hence there is alkaline pH. But if it is a type 4 RTA, what do you come across? Type 4 is hyporenemic hypoaldosteronism. No aldosterone, nobody to kick potassium H plus into urine. Right? Nobody to kick potassium in H plus into urine. Then what will happen to the urine? Typically what will happen to the urine in the case of the type 4 RTA? It should also be alkaline. It should not be acidic. Okay, so that is not a differentiating factor. Let's leave that. Okay.